Thank you everyone for joining. My name is Shad Reyes. I'm from Bento Medical Center. I'm joined with Dr. Kenton Zer. He is the Director of Cardiovascular Service Line at Bento Medical Center. We come to you every fourth Thursday at 7 p.m. Eastern Time to talk about clinical topic related to cardiovascular disease. This is called Heart to Heart series. This is a 1-hour CME activity, and you're gonna claim your certificate once you complete the survey at the end of the event. Again, the survey at the end of the webinar will be sent to you today or early thing tomorrow to complete it in order to get your certificate for 1-hour CME. This webinar will be recorded and will be hosted on the DMC Medical Group YouTube channel. So far, we have more than 16 lectures, all related to cardiovascular disease. Please make sure you stop by and learn from topics from experts in the field that has been talking about topics related to cardiology, cardiovascular surgery, and vascular surgery as well. Today, we are privileged to present Dr. Yusuke Terasaki. He is one of the cardiovascular surgeon at Bento Medical Center main campus. He has been pioneering multiple frontier in the cardiovascular surgery. And today he's going to be talking to us about topic related to aortic valve deformity called bicuspid aortic valve, which is considered the most common deformity for congenital heart disease, as well as aortopathy. Again, we're coming to you from Bento Medical Center, and before we switch to Dr. Terasaki, we'll start with this intro video. Thank you again for joining us. Dr. Terasaki, please go ahead and share your screen. Again, please use the chat function to ask any questions throughout the webinar. We'll try to address them at the end.
All right, are you seeing the slide?
We see the slides in presenter mode. If you can switch to display, Dr. Terasaki.
Is that better?
Still the same.
Still the same. No?
Still presenter mode. Perfect. Thank you. Yeah.
Okay,
Thank you so much.
All right. Well, thank you for that kind introduction, Shadi, and I'm happy to present this topic of bicuspid aortic valve. I titled it More Than Just a Valve Disease. And I did not create these slides as a comprehensive treatment guideline or a SAVR versus TAVR debate, but as a simple overview of the pathology of the disease and some of the nuances to think about when some of the interventional cardiologists and the cardiothoracic surgeons come to the same table at a structural meeting to talk about. All right, nothing to disclose, except for the fact that I will be speaking from the point of view of a surgeon. As Shadi or Dr. Zer, do you recognize who this is?
Absolutely, Arnold Schwarzenegger.
Yeah, this is the Terminator himself. So I don't think this is a HIPAA violation since all this is on Wikipedia, but he is very open about his history with bicuspid valve. And back in the 90s, he had his initial open heart surgery for his bicuspid disease. At the time, he ended up having what's called a Ross procedure, which I'll touch at the end of this presentation. Was followed by 2 additional open heart surgeries, I believe, and most recently he had a TAVR as well. From the surgeon standpoint, bicuspid aortic valve is something that we've always seen and noticed, especially when we operated for aortic stenosis and opened up the aorta, it's something that we noticed as opposed to having a tricuspid or tri-leaflet valve. Some patients had 2 leaflets or bicuspid leaflets. But all the same, the surgery itself was no different for us. So it's something that we've always kind of noticed when we did our operations. However, with now the advent of TAVR, which has been a very disruptive technology in a good way, which is a percutaneous approach of replacing the aortic valve disease for aortic stenosis, we have this whole slew of interest from interventional cardiologists now, and renewed interest among surgeons because of that. And there are a lot of literature and studies coming out saying that TAVRs are now safe in bicuspid valve patients, in high risk as well as low risk patients. So the question is, seems like the tide is really going towards the TAVR, and is this how it's going for the bicuspid valve, just like tricuspid valve aortic stenosis? Is it that it's going to be completely taken over by TAVR procedures now? So I want us to take a little pause here, and I really want to emphasize 2 points. One is that bicuspid valve disease is quite different from tricuspid valve disease. Okay, just point number 1. Point number 2 is that bicuspid valve disease is not only a valve problem; it's a constellation of problems that we need to think about. So in discussing bicuspid aortic valve disease, I think we need to go back and take a look at the anatomy in normal aortic root. So the aortic root is essentially the part of the aorta. I'm not sure if you can see me here. Part of the aorta that connects the left ventricular outflow tract below, as well as the ascending aorta. So the part that's between is the aortic root, which consists of the aortic valve leaflets, which in normal patients have 3 leaflets. And this is also where the coronary arteries come off of. You have the right coronary artery and the left coronary artery coming off of the sinus of Valsalva within the aortic root. So this is a cross-section of the aorta, and this is basically the view that we get when we open up the aorta during typical aortic valve surgery for us surgeons. So we call this the left coronary artery that's coming off, because this is basically to our left when we look down the aorta, and this is the right coronary artery that's coming off the aortic root. As you can see, you have the 3 leaflets. Down below, through the aortic valve leaflets, is basically the left ventricular outflow tract, or the LVOT. And you can kind of see the left bundle branch, or the conduction system that's running right here underneath the commissure of the right leaflet, as well as the non-coronary leaflet here. And you can see that this is really at the center of all the other valves, including the tricuspid valve up here, the mitral valve down here, and the pulmonic valve that's sitting right here. And how it functions is that during systole, when the heart squeezes, the blood obviously moves forward. And during diastole, when the aorta recoils, the tricuspid valve leaflets close shut, therefore shunting the coronary flow down the blood flow down the coronaries. And you can see that in normal aortic valve leaflets, again, this is tricuspid, you can see how thin the valve leaflets are. They're really tissue paper thin. And we really have to be careful as surgeons when we're doing a repair over the aortic valve, because we can easily tear these. Now, I really like this diagram, because this really shows the distribution of the coronary orifices off of the aortic root. And so this RCC is represented by the right coronary cusp, NCC is the non-coronary cusp, and the left LCC is the left coronary cusp. And obviously, the right coronary artery orifices come off the right, and the left comes off the left. But you can see that for some patients, the orifices come really close to the commissure, which is where the junction of the 2 leaflets are. And some coronary orifices are really down low in the coronary cusp. And this is particularly important when we start doing TAVR procedures, because when we deploy a TAVR valve in these patients with low coronary orifices, we have this risk of obstructing these orifices with the TAVR valves. And as you can see, this is a diseased tri-leaflet aortic valve stenosis. And you can see how thickened and calcified the leaflets are. And then you can imagine if you stuff a valve and deploy it and push these valves out towards the aortic wall, you can really obstruct the coronary orifices. Because this is how the TAVR is performed, by going in and deploying a valve and pushing the diseased valve out towards the aortic wall. This is not a concern in surgery or surgical aortic valve replacements, because as you can see, the first part of the procedure is actually removing all that thickened and calcified leaflets, as you can see here, and then reimplanting the prosthetic valve within the annulus. So this is not much of a concern in surgery, but is a concern when we start doing TAVR procedures. So why is 2 a bad number? Why is it that only having 2 leaflets is such a major issue? Since, as you can see, we have a leaflet or a valve called the mitral valve within our heart, which is bi-leaflet and then functions completely normally as is. So why is it that when the aortic valve leaflets are bicuspid, it becomes such a major issue? So bicuspid aortic valves occur in 0.5 to 2% of the population. And as Dr. Arraez has mentioned, it's the most common congenital cardiac defect. It is 2 to 4 times more prevalent in males. And it is a precursor of complications occurring a decade earlier than in tricuspid aortic valve patients. And they can manifest in setting of aortic stenoses, aortic regurgitations. They can manifest with ascending aortic aneurysms, as well as even aortic dissections. Majority occur sporadically. However, there have been noted to be familial bicuspid aortic valves, where the prevalence in first-degree relatives is almost 10%, which is very high. So how do we classify bicuspid aortic valves? Well, we classify with the system called the Sievers Classification, which basically uses the number of raphes that's present in the bicuspid valve. Now, raphes are basically the fusion of the 2 leaflets together. So as you can see down here below in this photograph, you can see that the left and the non-coronary leaflets have fused together in the middle, and this is what the raphe is. So you can have a type 0 or no raphe type. You can have a type 1 type of bicuspid where you have 1 raphe, just like in this picture, where the left and right leaflets are fused, the right non are fused, or non and left are fused. And you can have a type 2 where you have 2 raphes, which is very uncommon. Most common type of bicuspid aortic valves are the left-right fused one, and then the right non-fused one, which make up almost 90% of all bicuspid aortic valve disease. And again, this is not really an issue for surgeons because we take out the valve leaflets anyways. So the only thing that we may have to do a little differently would be to maybe rotate the prosthetic valve a little bit so that the post of the biprosthetic valve does not interfere with the coronary orifices. And the data proves this, because this is actually a study that came out really recently from the SDS this year. It's a data analysis of the SDS data set composed of 65,000 patients who underwent surgical aortic valve replacements over almost a decade. And you can see that the risk-adjusted 5-year mortality was actually even lower in bicuspid versus tricuspid valve replacements. So really, bicuspid valve surgery or replacement in surgery is no different than it is in tricuspid, even better. However, in TAVR, it's a little bit more challenging than that. Why is that? Well, for one, the leaflets are way more calcified. They've actually measured the weight of the excised valves. You can see that in bicuspid valves, the weight is way more. meaning that there's way more calcium burden on the leaflets. And that goes for both men and women. You can see that the calcium score is way higher for bicuspid patients over tricuspid. And for this reason, we have concerns of a higher risk of stroke when we're doing TAVRs on patients with bicuspid aortic valves. For number two, the calcium deposition is very eccentric. So this may prevent optimal expansion of the TAVR when we use balloon expandable TAVRs. And this may also lead to paravalvular leaks because the valve is not really sitting properly within the valve annulus. You can have an asymmetry of the actual geometry of the annulus, making sizing or pre-procedural sizing of the valve very difficult. And as we talked about, the coronary orifices are more frequently close to the commissures for bicuspid valves, and so this increases the risk of coronary obstruction during TAVRs. And most importantly, there is a concomitant aortopathy that cannot be addressed by the use of TAVRs. So this is just a reconstructed 3D CT images showing the different patterns of calcifications in different bicuspid aortic valve diseases. So you can see this is probably a type 0 or no RAF-A type. This is probably a type 1. This is a RAF-A right here. And then you can see that the orifices of the aortic valve is now asymmetrical. And here is a calcified RAF-A here. So there are different patterns. And here are actual depictions of the diseased bicuspid aortic valves. And you can again see the asymmetry that is present in all of these pictures. So are these concerns just theoretical, or do these actually, really happen? So now that we have all these imaging technologies, we can actually see how the TAVR valves sit in bicuspid valve leaflets. And you can actually see how wonky the valve looks when they have been deployed within the bicuspid valve. And you can even see this one, you probably have a little paravalvular leak going on right here between the valve and the native valve annulus. So you can see how malformed the valves actually are when they are deployed. Here's a computational fluid dynamics, they call it, but they were able to calculate the depict the deployment of the TAVR valve within a bicuspid valve, and was able to predict the amount of space between the two. And here they were able to actually depict or calculate and predict an amount of paravalvular leak just by CT scan. And when they actually got an echo on the same patient, you can actually see the paravalvular leak that's present in exactly the same location that they were able to predict using this computational fluid dynamics, which is really pretty incredible. This is another picture of how, because of the deployment of the TAVR valve in an asymmetrical manner, it's actually pressing on the aortic wall differently depending on which part of the aortic wall. And they were actually able to predict that the patient was going to have some type of conduction system, because if you remember, this is exactly where the left bundle branch in the conduction system runs. And they were able to accurately predict that this patient was going to have a complete heart block and required permanent pacemaker just based on imaging alone, which is pretty incredible. And these concerns are corroborated by data. And this is a study that came out of Cedars-Sinai that looked at all the TAVRs that have been performed over a 4-year time period between 2015 and 2018 in the US. And what they showed was that although there was no significant difference in the mortality between the TAVRs and bicuspids and tricuspids, you can see that there was a significant difference in the number of stroke rates in the bicuspids over tricuspids. And within the secondary outcomes, you can see that there were a significant number of pacemaker placements in bicuspids over tricuspids. Right? So these concerns are real. Having said that, we have been making improvements in the TAVR themselves. Even within the third to fourth generation TAVRs, there's been improvement in size measurements. These are preoperative CT scans that we perform to measure the actual size that we need in deploying these valves. They've made improvements in the outer sealing skirt, which are this area right here for the Edward Sapien, and these are Medtronic core valves. You can see that they've actually increased the amount of this outer wrap that hope to prevent that paravalvular leak. They've obviously made these delivery sheets smaller, and for the core valves, they made it so that they can recapture them, so that if they deploy it wrong, they can recapture it and redeploy them. So they've made some improvements in the TAVR. And you can see in the data, it's the same Sievers group published this a few years after, basically showing that there's really no difference in the mortality rate between the tricuspid and bicuspid valve. Even though it looks like there's difference, there's no statistical difference right here, as you can see. And there's no statistical difference between the stroke rates for the low risk patients. So when you look at the data, you might say, so I guess TAVR is the way of the future. No more surgery. Not so fast, right? This is actually pretty incredible. It's, again, the author is the primary author is different, but this is again the same group out of Cedars-Sinai, which actually looked at the different morphologies of the bicuspid valves. So this is a little busy slide, but I want you to kind of take a closer look. So they've analyzed all bicuspid valves and separated them into the no RAF-A group. Remember, there's no RAF-A, so bicuspid no RAF-A group here, the type 1 RAF-A group here, with no calcification of the RAF-A here. And you can see that this is the type 1 type with calcified RAF-A here. And then they've also separated them to mild leaflet calcifications on the top group, and then heavily or excess leaflet calcifications on the bottom. So they have 8 categories, and they looked at primary outcomes, which were all-cause mortality at 1 and 2 years, and secondary outcomes to procedural complications. So what they found was, this is pretty incredible. So the patients that had, no RAF-A had the least number of mortalities. When you had a RAF-A, it actually increased the mortality. And then when you have a calcified RAF-A, it even doubled the mortality rate. And this is all significant difference. Now, this is just per RAF-A. Now, how about in terms of leaflet calcifications? So when you had mild calcification, the mortality rate was 6.5 at 2 years. And that tripled when you had excess calcifications on those leaflets. But what's even more interesting is when you combine them. So about a third of the bicuspids were no calcified RAF-A or excess leaflet. About 40% were calcified RAF-A or excess leaflet calcification. And then about a third were calcified RAF-A plus excess leaflet calcifications. Look at this huge jump. So with no calcification or no calcified RAF-A or excess, the mortality rate was about 6% for 2 years. That almost quadrupled to 26% when you had patients with calcified RAF-A plus excess leaflet calcifications. I mean, this is really astonishing results. So, this is something that we really should be talking about when we're discussing whether these patients should undergo TAVR versus SAVR. And if they have no calcification, perhaps they can tolerate a TAVR. But if you have all this excess calcifications and RAF-A, maybe these patients should be going towards surgical aortic valve replacements.
Yusuke, there's a question from the audience talking about asking what causes the calcification?
What causes the calcifications? Well, most of the cases are degenerative. So even with tricuspid valve leaflets, which is the normal type, as you grow older, just like some of your vessels become calcified, your valve leaflets can be calcified. Now, this can be accentuated by other disease processes like hypertension, diabetes, if you have any type of endocarditis or rheumatic fever when you're a kid, all these can add up and probably accentuate these calcification processes.
But I would answer it in relation to the aortic or to the bicuspid aortic valve, the simple answer is the degree of deformity dictates the amount of calcification. So the simple way to think about it is a normal tricuspid valve opens in the shape of a soccer ball, whereas a bicuspid valve opens in the shape of a football. So there's turbulent flow, and that's what you hear as a murmur when a teenager gets their physical exam and they're told they have a murmur. In all likelihood, they have a deformed bicuspid valve, which causes turbulence. So turbulence beats up the edge of the aortic valve, and the valve itself cannot repair itself. Those cells don't repair themselves, and they get early calcification, which is why bicuspid valves present 10 to 20 years earlier than tricuspid valves in terms of the aortic stenosis. So I think the simple answer is the degree of the deformity and the turbulent flow across that valve dictates how early and to what degree that valve becomes calcified. I think that's maybe the answer you're looking for.
That's absolutely right, and I'll have some pictures in the next few slides that will depict the changes in flow as well. So what we haven't discussed is kind of the elephant in the room, which is the aortic aneurysm that's associated with bicuspid aortic valve leaflets. And these are a few depictions of aneurysmal aortic valves. This is the heart, and this is the aorta, and this is a completely abnormally enlarged dilated aortic root, ascending aortic aneurysm, as you can see here, ready to be repaired. And so how do these, why do these patients end up with aortic aneurysms? That's the question that we like to ask. One, as we talked about, a lot of cardiac disease is caused by increase in age, comorbidities such as diabetes, cholesterols. If you have aortic regurgitation at baseline, if you're a smoker, these can lead to aneurysms. You can have some epigenetics like microRNA and histone methylation that can lead to bicuspids. Genetic predispositions. You can have intrinsic aortic wall deformities or composition that lead to bicuspids having aneurysms, as well as hemodynamic turbulences, which is something that we just touched on, that can alter the wall stress of the aorta that can cause aneurysms. And I'll touch on a few of these things. But what's most interesting is that this is a study that came out of Denmark looking at, basically they did an echo of all 25,000 newborns that were born within the city of Copenhagen between 2016 and 2018. And they diagnosed approximately about 0.8% of the population as having a bicuspid, which is within that 0.5 to 2 range that is known. Male to female ratio, again, is a little higher for males, 2 to 1. They found that patients with bicuspids had more aortic regurgitation compared to patients with normal anatomy. And you can see that already patients with bicuspid aortic valves had a concomitant aortopathy in a third of these newborns. You can see that the flow velocity in the bicuspids were higher, and the aortic root and the ascending aortic diameters in these bicuspid newborns were greater, significantly greater than in normal anatomy. So, we're actually, the patients with bicuspids are actually born with this enlargement of the aortic root as well as the ascending aorta. We talked about genetics. So there's a whole slew of genes that are associated with bicuspids, as you can see. Some are specific to bicuspid aortic valves, and as you can see, some are present in connective tissue disorders like Marfan, like as you can see here, and Louis-Dietz syndrome, as you can see here. So a lot of genes connected to bicuspid aortic root aneurysms. And here's the hemodynamics that we talked about. So this is what's called a 4-dimensional flow MRI of a tricuspid valve, so normal anatomy. You can see that there's really a good laminar flow past the aortic valve, up the ascending, across the aortic arch, and down the descending. There's really not much turbulence. Whereas in patients, this is for right-left type 1 type of bicuspid aortic valve leaflets. You can see that there's a whole slew of turbulence that's really hitting against this anterior wall of the aorta, which is extremely common when surgeons go in and find a bicuspid valve. They see concomitant dilatation in this exact area where basically the flow is hitting against the aortic wall. So this team out of Japan took a step further and actually recreated a different type of valve anatomies using bovine pericardium. So you can see that here is a normal anatomy of tricuspid aortic valve that they recreated. They created an asymmetric type of bicuspid aortic valve. So this is kind of like the type 1 BAVs that we talked about. And this is the symmetrical type of BAV, which is almost like the type 0 or no raphe type of valves. So they recreated all these type of valves using bovine pericardium, and then recreated this pump that resembled a human heart and ran it through this 4-dimensional MRI and looked at the stress that the flow had against the aortic root as well as the different parts of the aorta. So for the tricuspid aortic valve, which is the normal anatomy, you can see that there's good laminar flow. There's really no flow disturbance at all. This is the type 1. This is the most common type, the right-left fusion type. And you can see that the flow is bumping right against that anterior ascending aortic wall that we commonly see during surgery. This is the right non-type, which is the second most common type of bicuspid valves. And you can see that for these patients, the flow is actually hitting almost the top of the ascending, almost the arch. And these are the less common type of bicuspid valves. This is the no raphe type 0 type, which is also hitting against the side of the wall. So you can see that bicuspid aortic valve leaflets produce this flow of blood that is stressing on the wall. So there's definitely an argument that hemodynamics is causing these aortic aneurysms, right?
Dr. Terasaki,
Yes.
So just to answer the question that was brought up, this is the hemodynamics that Dr. Zer mentioned that causing the calcification because of that turbulence.
Yeah, exactly. The same type of flow disturbance that's causing the calcifications of the leaflets, but it's also causing disturbances and wall stress on the aorta themselves. And that's what these pictures are depicting, is the wall stress that the aorta is feeling.
And, Chadi, we know this goes on for years because, like when you're in clinic with a patient like this and you ask them, when were you first told you had a murmur? And they'll tell you it was, during a high school physical or when they had an exam in college. But, that's been years, that was 20 years prior to them presenting with these complications down the road of their bicuspid disease. So this pattern gets set up early on.
Yep. Before we move further, there's a question. Do you have to wait to get bicuspid valve fixed, or do you have to wait until aortic stenosis or other complication happen before you fix?
Well, so are you talking about the valve or the aorta?
The valve. So I'm
one or the other or both.
The valve, yeah.
And
so the question is, you have a valve,
the
that's
valve,
bicuspid, yeah.
Mm-hmm. Yeah, for the valve, we treat it just like we do with other aortic, like normal tricuspid aortic stenoses. And we have the severity that we measure based on echo or left-sided cath, where we measure the gradients across the valve. And if you have a severe aortic stenosis based on those studies, then whether it's tricuspid or bicuspid is the timing of when we should replace them or fix them.
The question, I think, Dr. Terasaki, is that you have that Dr. Zer mentioned, you hear a murmur, you do echo, you find a bicuspid valve. Do you fix it right away, or do you wait till it degenerate to stenosis or regurg before you go after it?
Well, I think we wait until we have the severity, just like tricuspid valves.
Right, and remember that the majority of the bicuspid valves that exist in the human population take the person to the whole way through their life. It's only a proportion that becomes stenotic or regurgitant or develop an aortopathy. So those 0.5 to 2% of the population, the majority of those patients will never need anything done with their valve.
Right. The other question coming that's related to the aneurysm now. Do you have to screen for thoracic aortic aneurysm in patient with bicuspid aortic valve? And what size do you decide to repair the aneurysm?
We'll talk about that. That's all in my slides. Yeah, we'll
Exactly.
talk about that. All right, so is it just the hemodynamics that's really causing the aorta to become aneurysmal? Well, that might not be the case, as you can see in this study, where they actually looked at the size of the aorta per year after the patients had their valves replaced for bicuspid as well as tricuspid valves. Just to reiterate, so this is bicuspid aortic valve who have been operated on with the white bars, bicuspid aortic valves that were not operated on, the black bars, and these are the tricuspid valves that have been operated on. And you can see that for these bicuspid aortic valve patients who had their valves replaced, their aorta actually increased in size even after the surgery took place, which argues against the hemodynamic only theory, because something else must be actually increasing the size of the aorta as well, in addition to the hemodynamics. So what could that be? So the other theory is that there's probably an intrinsic aortic wall property that's also leading the aorta to become aneurysmal. And this is just a simple diagram of the aortic wall, the inside being the intima, the media, and the adventitia. And within the media are the extracellular matrices. Within it, we have these yellow Pac-Man looking things, which are basically depictions of these matrix metalloproteinases, which is responsible for remodeling of the aorta. And these green triangles, which are the tissue inhibitors of these metalloproteinases. And you need this balance between the MMPs and the TIMPs for normal remodeling to occur. And if you have an increase in the MMPs or a decrease in the TIMPs, you might actually have too much remodeling or fibrosis that lead to aortic aneurysmal dilatation. So I had to dig deep to remember, how the angiotensin pathway worked. But if you remember from medical school, so angiotensin 1 gets clipped by the ACE inhibitor to become an angiotensin 2. There are two pathways that you can go from angiotensin 2. There are two receptors that they can attach to, AT2 and AT1. If it goes down the AT2 route, it actually decreases the MMP, that protein that kind of degrades the aortic wall, and so it has a protective effect. Whereas if you go out the AT1 receptor route, it actually increases the amount of MMP production, and therefore there's an increase in remodeling fibrosis that occurs, and that this might cause more aneurysmal dilatation. So if there's a medication that exists that will just cut out this pathway, then we're golden. We might be able to actually stop the dilatation of the aorta. Well, what medication is there? There you go, losartan, an ARB. Actually just targets this pathway. And so it might actually have a protective mechanism against the dilatation of the aneurysm. Is there a study? Yes, there's a study. So this is a study that came out of the Netherlands. That this is not for bicuspid patients. This is actually for Marfan patients. But a long-term clinical outcome of losartan in patients with Marfan syndrome. And they looked at these patients over a span of almost 10 years. And they can see that the patients who took losartan, as compared to controls who just took beta blockers, I believe, for blood pressure control, they had a decreased number of patients ending up with root replacement, reoperation, operations for aortic dissections, and all-cause mortality. So there's definitely some benefit to using that ARB in kind of preventing some type of catastrophic event from occurring from aortic dilatation. So to summarize, there is a whole slew of different etiologies for why these patients with bicuspid have these progression of aortic aneurysms. But why do we care so much about the aneurysmal dilatation? Well, So this is what's the natural history of bicuspid aneurysms. This is the aneurysmal aortic root. So once it reaches a certain size, then there is a high risk of this leading to what's called a type A dissection, which I had covered in my last topic. And this is actually a dissection that I performed here at Harper. But the layers of the aorta has now separated, and you can see this kind of thin film with blood within the layers, different layers of the aorta. So this is called an aortic dissection. It is catastrophic because this can lead to eventual rupture or cause coronary obstruction or even stroke. And so this becomes a emergent open heart surgery. And so this is what we're trying to prevent when we are following these patients with aneurysmal dilatations and bicuspids. So we talked about the natural history. The biggest data comes out of the Cleveland Clinic, where they studied almost 1,200 patients with bicuspid aortic valves with an aortic diameter of 4.7 centimeters. More than half, almost 2/3 of the patients underwent aneurysmal repair before anything had happened. But what we should look at are the patients who did not undergo surgery during this time period. You can see that of those 380 patients that did not undergo surgery for aneurysm, almost half of them actually underwent aortic surgery anyways during follow-up. 10 of those 280 patients, or 2.6%, ended up suffering from type A dissection. And they were able to calculate a risk-adjusted probability of dissection to be 4% when the aortic root diameter was 5 centimeters. And the probability of dissection was, again, about 4% when the ascending aortic aneurysm diameter was 5.3 centimeters. All this to say that both the SDS as well as the AATS, which are the two biggest societies in cardiothoracic surgery, both recommend repairing the ascending aorta or the roots when the size reaches 5 centimeters, as you can see from the AATS as well as from the SDS. The SDS actually adds, which I think is important, because you can think a 5 centimeter size aorta in a tiny little lady is different from a 5 centimeter diameter in a giant 6.5 feet man. So they actually recommend measuring the height and come up with a ratio between the diameter and the height of the patient in determining whether the patient should undergo surgery. They both also recommend that patients who have another surgery having another open heart surgery, for example, like aortic valve replacement, go ahead and get the aortic root or ascending aneurysm repaired at size 4.5 centimeters. So this is coming from both the AATS and SDS recommendations. So what are some of the surgical techniques? Well, I'm going to just touch on it without really describing too much in detail. Sorry, I'm not sure where my pointers are going. Okay. So when you have isolated aortic valve stenoses from bicuspid valve disease and an ascending aneurysm, you can just replace the valve, as you can see in this diagram, where you cut out the valve leaflets and reimplant a prosthetic valve, and then cut out the aneurysmal part of the ascending aorta and replace it with a synthetic graft, as you can see here, which is a pretty simple procedure in itself. So it just adds maybe another 30 minutes of surgery to do this part, in addition to a simple aortic valve replacement. What if, sorry, my clickers are not working. Can you hear me still?
We can. I just wonder if you froze. I had this happen. There you go.
That's fine.
Yeah, there you go. Okay. All right. So what happens if you have a dilatation of the roots, not the ascending, but the actual, the bottom part of the aorta? Then it becomes a little bit more complex, where we had to take these coronary oars as buttons, we call it. So we basically separate out the coronaries like this, take out the entire root and the valve, replace the valve, and put a conduit and re-implant the coronary to the graft. And this is called a Bento procedure, or an aortic root replacement. The surgery has become a little bit more simplified because these industries have come up with what are called aortic valve conduits, which is basically a combination of the valve with this tube graft. So you don't have to, create this on your own at the bedside when you're operating. And so they are what are called mechanical valve conduits, and this only came out the last couple of years, where you can actually have a bioprosthetic valve or a tissue valve conduits that make doing a Bento procedure much more easily. This is just touching on the Ross procedure, which is the procedure that Arnold Schwarzenegger had in the 90s. So why did he have that done? Because he did not want to have a mechanical valve, number one. I think he was in his 40s or 50s, so he was pretty young. And he did not want to be taking Coumadin for the rest of his life when he was, basically fighting off zombies and, monsters or whatever he does. So he did not want a mechanical valve. And obviously a bioprosthetic valve was not going to last, long enough. So the option back then, or even now, is basically to do a Ross procedure, which is a very much more complex procedure, where you basically take out the part of the pulmonic valve of that same patient. Take out the defective aortic valve and replace it with its own pulmonic valve. And the space that's now, open, the pulmonic valve, you replace it with a homograft, or basically a cadaveric pulmonic valve from somebody else. So what you're doing here is you have basically an aortic valve disease or one valve disease, and you're kind of setting them up for a two valve disease potential. And that's exactly what happened to Mr. Schwarzenegger, where he actually needed to have this pulmonic valve replaced again, and then I think he needed to have a TAVR done for this again. So even though this may have lasted longer, these patients require to go back to the operating table, maybe once or twice in their life after this. The other procedure that I wanted to touch on is this newer procedure called the Ozaki procedure, which might actually replace, the Ross procedure if the outcome is good as they say it is. But this is where we go in and we take a piece of pericardium of the patient in the beginning of the case, and they provide you with the stencils for the sizing of the valves, and you basically cut out these leaflets in the size of these patients' aortic valves and sew them on to the aortic root. So you're recreating the aortic valve leaflets using their own body parts. So the midterm outcome of this Ozaki procedure is at least equivalent to TAVRs and bioprosthetic valves, which is great. And because this is autologous body part, it's its own body part, the pericardium, it might actually last longer. And if it does, then the outcome might actually surpass the TAVR or the bioprosthetic tissue valve, and these patients might not even require a Ross procedure and can have this and not have to take any blood thinners and not have to undergo more procedures down the line. But again, we still do not have a long-term outcome data yet on this procedure, but the mid-term outcome is at least equivalent to TAVR and bioprosthetic valves. So the take-home message for this is that, again, bicuspid aortic valve disease is not just a valve disease. As you saw, you can have aortic aneurysms in addition to the valve disease, and that can lead to potential for type A dissections, and that's a real risk. So it's really critical to have, especially when the interventional cardiologists and the cardiac surgeons gather around the table to discuss these structural cases, I think it's really important that we talk about all these nuances when we decide whether the patient should benefit from a TAVR versus a surgical valve replacement. And again, the management, there's no strict guideline at this moment in terms of how we should be treating this. And the management will likely be very dynamic, especially we saw all these studies with these improved technologies and imaging. And so perhaps maybe in a few years we'll be able to predict which of these bicuspid patients will require a prophylactic type of aneurysmal repair based on the type of valve morphologies. Okay. And that ends my share.
Thank you so much, Dr. Terasaki. Phenomenal talk. We have been getting some questions starting from screening. Like we have some primary care, also like medicine, as well as general cardiologists. In terms of screening, how often do you screen for these patients who are already identified as bicuspid valve, a yearly or more frequent? And when do you screen for the aortic aneurysm?
You're talking about the screening for the aneurysms.
Aneurysm, and how often do you follow? How often do you follow the bicuspid valve?
Right. So once once we diagnose any patients with aortic aneurysms, my usual course is that I get another CT scan or echo or ultrasound to measure it within 6 months. And if it hasn't changed much size within those 6 months, then I would do it annually thereafter. But within those times, if there's an increase in the size by more than 0.5 centimeters, that's an indication for us to take a closer look.
There's some, Chadi, there's several guidelines. We're all well aware now that the guidelines for bicuspid aortic valves with an aortopathy is 5 centimeters. Just as a general rule, when they hit 5 centimeters, it's time to do them. And as Yusuke pointed out, 4.5, if you're doing the valve itself and the aorta is 4.5, you should probably do the aorta at the same time. So then, any major aortic center which follows patients with bicuspid valves that have a known aortopathy, but still a functioning aortic valve, then we need to follow those patients. And generally we follow them with serial CT scans at 1 or 2 years interval. And then the other thing is, when you talk about screening, what do you do when you have a patient that has a bicuspid aortic valve? And frequently, particularly if they have concomitant aortopathy, well, the patients will ask you, should our kids be screened? And I don't think there's really any clear guidelines, but I always say they should get an echo.
I agree. I mean, this is our practice too. Anybody with a family history, you should screen the siblings as well as the offsprings of the family. Another question.
Sorry, I forgot to mention that under the guideline of AATS, there's one part that I actually missed, is that if they have any family history of sudden cardiac death or type A dissections in patients with aortic aneurysms, they should be repaired at a size of 4.5 rather than 5 centimeters.
Agree. A question came, in your experience, patients with HIV who have aortic aneurysm are more prone to early dissection?
With HIV, to my knowledge, I do not know if there's any connection between HIV and aortic aneurysms. Dr. Zare?
Now, I'm not aware of any either, other though anecdotally, I've had several HIV positive patients that have had type A dissections, but there's no, I don't think there's anything in the literature that there's a connection, say that there's a weakness in their wall.
Great.
This is this bicuspid aortopathy has been a very interesting discussion over the course of several decades now in cardiothoracic surgery. Number one being when you fix them, and number two being, do they or do they not have an aortopathy? And Yusuke presented both sides of that equation. And I think there is both sides of that equation. There are bicuspid aortic valve patients that do not have an aortopathy, and then there are bicuspid valves that have an aortopathy. And we know that bicuspid valve disease is associated with other problems, like even congenital problems. Like, for example, every pediatric echocardiographer, when they finish up their study, they do a suprasternal notch look down the aorta to rule out whether or not the patient has a coarctation. And we know that bicuspid is associated with coarctations. And so there are other abnormalities that exist with bicuspid aortic valves, which behooves the physician to do a careful screening of those pathologies.
Absolutely. So, Dr. Terasaki, to summarize, when do you fix the bicuspid valve? When we should refer patients to a surgeon to repair or replace the aortic valve?
I think as soon as you have a diagnosis of a bicuspid aortic valve that is at least moderate in severity in terms of stenosis, or if you have any concomitant aortic valve regurgitation or any changes in the abnormalities in the size of the aorta, I think that's the time when we should start following the patients as well alongside the primary cardiologists.
And from a surgeon perspective, Dr. Zer, do you prefer for you to see these patients, even if they are not at the threshold to repair the valve or the aneurysm, to see them routinely? And then you decide on the surgery?
The valves, no. I'm totally happy with you following the patient until they hit severe aortic stenosis. But the aortopathies, I like to get them into clinics so that they get used to seeing the surgeon, to have that discussion every year that their aorta is 4.9 centimeters and they're 1 millimeter away from being done, and it's time to start thinking about it.
Correct.
Because there's a price to be paid for waiting. And we all know of a few of those examples, like John Ritter, who died of an aortic dissection when he had a known aortic aneurysm that was being followed. And we all have patients in our practice that waited too long to get their aneurysms fixed. So, you take a 1 to 2 to 3% mortality operation, and if they have a type A dissection, it becomes a 20% mortality operation. So, it's important to do the prophylactic fix.
What modality do you prefer to look at aortopathy? CTA, CT angiogram, or MRI?
I personally like the CTA, just because I'm used to looking at CT scans on my own, and I can actually pull out my little measuring stick on the CT scan and measure it myself, because the way that you measure it is also important. And sometimes the measurements that the radiologists give you is not so accurate. And so I like to kind of compare the historic CT scan with the current CT scan and measure exactly the same location and see if there's any changes in the diameter myself.
You agree, Dr. Zer?
Yeah. I mean, Yusuke touched right. He said it. When you take a tube, if you measure it oblong, you can make it any size you want. So it's very important that you measure in the smallest diameter so that you know that they're the actual diameter and you're not measuring it oblong. And so Tor Sunt has a beautiful slide depicting that, how it's very important to make sure you measure the appropriate spot so you know you're getting the diameter and not some oblong ratio. Like, for example, you'll read a radiology report and it'll say that the aorta is 6 centimeters by times 3.5 centimeters. Well, it's a round tube, so it can't be 6 centimeters by 3.5 centimeters,
Right.
It's 3.5 centimeters.
Reading this way versus
versus oblong. So people like us are used to spatial orientation. We think that's kind of amusing, but it's important that we get to measure those patients ourselves.
Absolutely. So I think we covered all the questions. Dr. Terasaki, really appreciate your expertise, as well as Dr. Zer for your wonderful comments. I'm going to be, this is the number to call if you have any referrals or any patients with aortic dissection or aortic aneurysm, as well as any valve heart disease. Please call this number. One of our surgeons definitely will be happy to see these patients. Again, as a reminder, this is a CME activity of 1 hour AMA category 1. We are going to receive a survey at the end of tonight or tomorrow. Complete the survey. Please give us your honest feedback about the activity and what topics you suggest for future meetings as well. Dr. Terasaki, really appreciate your time. I would like also to thank Elise as well as Sherry for putting this CME activity together and for bringing this activity. All what we did is just clicked on the link and we showed up, and the heavy lifting was from Elise as well as Sherry, and for sure our speaker, Dr. Terasaki, for putting this wonderful slide deck together.
Beautiful slides.
Thank you for having me.
Again, reminder, this is an activity come to you every month on the 4th Thursday at 7 p.m. Eastern. We received a lot of wonderful feedback from Rana, Ishmael, and other audience as well. Thank you all for attending, and please enjoy your evening. This is sharp 7 o'clock. I wish everybody a good evening. Dr. Terasaki, Dr. Zer, thank you so much for being here.
And
Thank
see
you.
you all,
Have a good night.
see you all next month.